Thank you. So first, I want to thank Hattie Henley, Rana, and the Right Care Initiative for the introduction and for bringing us all here today. This initiative has been such a vital force in advancing evidence-based strategies to improve cardiovascular outcomes. And I'm very grateful for the opportunity to be part of this mission. And I want to recognize all of you who are here today. I mean, taking time off your busy schedules, your clinicians, pharmacists, dietitians, administrators, you're all coming here to improve the care of your patients and just shows your dedication. And it's this collaboration what makes progress possible. I just want to point that out. So I'm going to be talking about team-based care, cholesterol management, and I'm very fortunate to be here today with our prevention team, our cardiovascular pharmacist and the care team, Paige Hutchison, and our dietitian. And we are here to highlight the importance of this integrated team-based approach to lipid management for cardiovascular prevention. I am going to begin with a brief discussion, or not so brief, but team-based cholesterol management, the importance of low-density lipoprotein measurements and control as performance measures. Here are my disclosures. Before we dive into the specifics of cholesterol management, I want to take a moment to step back and realize that there's a broader landscape, right, of cardiovascular disease prevention. There are a few ways to assess risk. And of course, everyone is familiar with secondary prevention over here. That is treating disease, or primary prevention, where we're treating risk factors. But even, of course, there's primordial prevention, trying to prevent the development of these risk factors in the first place. And that's really relevant as we're talking about patients with elevated cholesterol, because there's a lot that can be done in terms of health behavior, social determinants that will influence the long-term heart health consequences of this and how we can mitigate this. And one of the most important shifts in our thinking is in the increasing focus on primordial prevention, intervening before these risk factors even develop. Initiatives like the AHA 2020 Impact Goal, Million Hearts Initiative, global efforts from the Institute of Medicine, all really need to be emphasized and emphasize the shift. Prevention needs to start earlier. It needs to be broader in scope. But also, these frameworks raise a few questions, right? Key practical questions. Who should we be targeting? When and where should we intervene? And how can we ensure that these efforts are sustainable in real-world settings? So I want to keep these in mind. So cardiovascular disease remains the #1 cause of death in the US. And as Hattie mentioned, primarily driven by atherosclerotic cardiovascular disease, or ASCVD. The graph here shows or represents age-adjusted mortality rates for atherosclerotic heart disease among individuals aged 35 and older, using data from the CDC Wonder database. These rates are stratified by year and sex, and highlight the overall, here in the middle, male and male on top and female at the bottom curve, using from years 1999 to 2020. So as you can see, we made great strides, right? Nearly 50% reduction in cardiovascular disease mortality achievement that was largely attributed to, push from smoking cessation, use of statins for lipid management, and widespread use of ACE inhibitors for blood pressure management. We had seen this decline consistently, and then around year 2010, the curve started to flatten out and started to plateau. However, this progress that was so marked was not across the board. And most of the decline has occurred in older adults, especially those over age 55. Among younger adults, particularly those between ages 35 to 55, mortality rates have plateaued or rising mortality trends. We see that trend here at the graph on the end. The curves are starting to go up. So this highlights urgent need for earlier, more targeted prevention strategies. So what do we do with this information? So we need to take a step back and ask, are we treating what matters most? We know that there's the three major modifiable drivers of ASCVD: LDL cholesterol, blood pressure, and glucose, as Hattie showed us very nicely at the start of this talk. These are not just correlated with cardiovascular disease, they're causal to cardiovascular disease, and we have vast amount of data showing that managing them improves outcomes. So in many ways, our quality assurance systems, right, are built to support that goal. And especially when it comes to hypertension and diabetes. We have national quality metrics that track not just whether we're measuring the risk factor, but if we're controlling it, right? But LDL, for example, A1C less than 8, blood pressure less than 140/80. But LDL has been treated differently. We step back from the metrics, as Hattie was pointing out. LDL less than 100 used to be a metric that was measured, but since 2015, the metrics were replaced with a simple statin prescription, yes or no metric. So no tracking of adherence, intensity, or LDL levels achieved. So what happens with this? What is the result? First of all, there's a disconnect between guideline-based care and the performance measure. We know that LDL cholesterol is a class 1A guideline recommendation, and we're missing opportunities for impact. So again, when LDL isn't measured, prevention falls short. Since the LDL metric was removed in 2015, statin use is stagnant, only a 2 to 5% increase between 2016 and 2020. That's not really an increase, that's stagnation. And in patients with clinical presentations of ASCVD, we only have 50% of these patients nationwide on a statin, and less than 25% receive high-intensity therapy, despite this being standard of care. So these treatment gaps matter. They contribute to heart attacks, more stroke, greater cost, and persistent health inequities, okay? This affects mostly people who are less likely to be diagnosed: women, racial and ethnic minorities, and those with lower socioeconomic status that don't have so much access to care. And why does this matter? Because LDL is not just a marker, like we said, it's a cause. And the evidence is overwhelming, right? LDL cholesterol is a causal driver of atherogenic cardiovascular disease. It isn't based on a single study or method. We have converging proof from every angle: large-scale observational studies, Mendelian randomization from human genetics, rigorous randomized clinical trials, and consistent findings from animal models, animal experiments. And this is why LDL is still the primary target, and why lower LDL for longer is the mantra. It's the rule for cardiovascular prevention. Okay, so this is just a graph to support that at every criteria for LDL causing ASCVD, note that the evidence grade is class 1 here. This is from the European guideline. It's across the board. And this is highlighted here, where we see that the magnitude of exposure to lower LDL, so mind you that the lower LDL is to the right of the graph, so LDL levels are decreasing to the right down here, and is proportional to the reduction in risk of coronary heart disease. So going up the scale is better, less heart disease. So what's really powerful is powerful here is how consistent the relationship is across the different types of studies. So we have the genetic studies here on top, cohort studies in the middle, and randomized controlled trials at the bottom. And the more we lower LDL to the right, we see lower coronary heart disease, and that relationship stays proportional, right, at all levels of evidence. But there's another important message here. Lower for longer really matters. So if you look at the genetic studies at top, people who have had lower LDLs from birth, so the median follow-up here was 52 years, right? You'll see I've drawn a vertical line here at the 1 millimole per liter mark, or about 38.7 milligrams per deciliter of LDL lowering. These people with 1 millimeter of 1 millimole magnitude of exposure decline have about a 50% reduction in the risk of coronary heart disease. Compare that to the randomized control trials here at the bottom, right? Where LDL is lowered on average for about 5 years, and you'll see benefit, but it's closer to 20% down here, right? So there is still a proportionate reduction in the risk when you lower LDL, but you have to have it for longer. And there is a larger magnitude of reduction. So the key takeaway here is earlier and longer we keep the LDL low, the bigger the impact. And this comparison drives home the urgency of early identifying these patients and sustained treatment of elevated LDL, because the benefit of LDL lowering isn't just dose dependent, it's time dependent. And so here, I really like this schematic because it reframes how we think about LDL exposure over time. So we're all very familiar with the concept of pack years when talking about smoking. Both the intensity and the duration matter, right? And in the same way, we can think about cholesterol years. Cumulative exposure of the artery wall to this LDL cholesterol, it's not just how high your LDL is at a single point in time, but how long it's been elevated. There's a theoretical threshold here. This line across is the onset of clinical ASCVD, when it occurs. People have speculated that that's around 5,000 milligram per deciliter years. And people with familial hypercholesterolemia, here, this very steep curve, this first one on the graph, they've had high cholesterols from birth, and they reach this threshold very early on in their years, right? They're young, they have clinical manifestation of heart attacks. I've seen an 11-year-old have a heart attack. So these are very dramatic cases, right? In contrast, this lower curve at the bottom shows a patient, someone with genetically low LDL, healthy lifestyle habits. They may never reach that threshold, right, in the whole lifetime. But what I really wanted to emphasize here is the group in the middle, this one, the modest hyperlipidemia, but persistent elevation, say LDLs in the 120s to 150s. This is often overlooked in clinical practice. And over time, these modest elevations may also reach that threshold earlier in life, right? And that's why two people with the same LDL at age 40 could have very different cardiovascular risk depending on when their elevation began. This is why we need to start thinking about LDL prevention earlier, not just reacting to clinical ASCVD presentations later when they come in with strokes or heart attacks. And let's move on to this slide helps us understand why when we treat LDL cholesterol is just as important on how much we lower it. So this curve illustrates the rise, LDL cholesterol rise across lifespan, the cumulative integrated LDL exposure in individuals with familial hypercholesterolemia, like we mentioned. This happens earlier, and with earlier onset of atherosclerotic disease. The key point here is the LDL reduction needed for 50% risk reduction is going to get more intense. We need to lower it more, not just 35 milligrams per deciliter, let's say, but 100. Once this plaque progresses from fatty streaks to more complex plaques, so as the arterial wall gets more complex, our magnitude of lipid lowering is going to need to be much more intense to get significant reduction in risk. So the graphs just underscore that it's not just how low you go with LDL, but how early you get there that really makes a big difference. Building on that, about timing and disease phases, this slide just shows us the other kind of half of the story, how far down we can go with intensive LDL lowering, even in advanced atherosclerosis, right? So over the last few decades, we've shifted away from just slowing progression to actually reversing plaque burden in high-risk patients. People get very excited with these concepts. You tell them there could be plaque regression, their eyes light up and they're all in. And so it started with this reversal trial, this first one here, that is a graph where we see that patients with a baseline who had a baseline cholesterol of about 150 milligrams per deciliter. Here we plot the change on plaque amount versus the progression from baseline. In people who were given just pravastatin, they achieved an LDL from 150 to 110. You see that there's no plaque regression. If anything, we see atherosclerotic progression from baseline. However, in people who were given high-dose atorvastatin, they lowered the LDL from 150 to 79. There was no significant change from baseline. Atherosclerotic progression was stopped, right? And then came Glasgow study when we finally could get those LDLs below the 70 mark consistently with PCSK9 inhibitors. This study shows the effect of evolocumab. we were able to get LDL reductions in this trial to 36 milligrams per deciliter. And this time we saw a significant reduction in atheroma volume. In fact, 64% of these patients actually showed some plaque regression. And then more recent trials like Pac-Man took this to even a step further, down to 23 milligrams per deciliter. We saw what it's called triple plaque regression, reduce in volume, lipid core depletion that is very important to reduce rates, and fibrous cap thickening that stabilizes these plaques. So the data is clear. The lower you go, the more benefit you get, and in high-risk patients, aiming below traditional LDL targets can lead to improvements. Now, how do I advance this here? Okay. So the next slide kind of brings it all together, from reversing plaque to reducing actual events, right? Major cardiovascular events, cardiac death, MI, stroke, CHF hospitalizations, revascularizations. What we're looking at here is one of the most foundational relationships in cardiovascular prevention. As the LDL levels fall now here from about 200 down to almost zero, right? We see that there is no threshold effect. There is a drop of major cardiovascular events all the way down to almost zero, right? And for every about 10 milligrams per deciliter decrease, there's about a 1.6% reduction in 3-year cardiovascular event risk, which leads to about this 24% reduction with the 39 milligrams per deciliter, as shown in the Odyssey trial. Importantly, this benefit doesn't stop here when LDL hits 70 or below 70. It keeps going. In this 4-year OLES trial, patients who achieved LDL cholesterol as low as 7 milligrams per deciliter continued to see risk reduction with lower event rates without safety concerns, even at these very low levels. And how do we use this in clinical practice? Well, we take patients with LDL, if we take patients post-PCI who have LDLs less than 70, their MACE rate goes down to 55.2 every 1,000 person years, versus those whose level remain above 100, that their major cardiovascular event rates are as much higher, 94 per 1,000 patient years. So in high-risk patients, we're aiming consistently for these LDLs below 55 or less than 70 if patient is not as high risk. So this brings us on how do we apply all this data in clinical practice. So luckily we have guidelines. We have these guidelines that direct us. We've seen how lowering LDL reduces cardiovascular events in a continuous linear way, even at very low levels. Now, the guidelines help us translate that evidence into specific LDL goals here, and based on total cardiovascular risk. And these are the European Society guidelines and the updated recommendations from our clinical decision pathways from the ACC and AHA that we've talked about in other sessions mirror what the Europeans had put forth many years ago. We finally have that in our guidelines, and it's based on targets, right? We have 2 targets, more than 50% reduction from guideline and then from baseline, and then LDL targeted reductions below 55 in very high-risk patients. So these are people who've had atherosclerotic cardiovascular disease, who have also severe kidney disease, diabetes with target organ damage, or that have significant vascular calcium or coronary disease on imaging. And that brings us to the concept of plaque burden, right? Imaging has been very helpful. We talked about tailoring LDL goals based on risk, and now I want to show you this slide on how coronary calcium helps us to risk stratify patients with greater precision. Coronary calcium score is one of the strongest predictors of future cardiovascular events, even more so than traditional risk factors. And that's why our guidelines give it a class 2A recommendation in patients who are borderline risk or intermediate risk, and we want to know if to start a statin or intensify therapies, for example. Do we give this patient a PCSK9, or are they going to be somebody who will treat with these anti-LPA lowering drugs in the future, right? This can help you skin that cat. So critically, patients, this slide introduces a staging framework for coronary calcium, and it was developed here at the Right Care Initiative and led by Dr. David Maron to help translate coronary calcium findings into action, right? He called it a proposal and a call to action. And so this system gives us a shared language for treatment planning and patient communication. So critically, patients with a calcium score, for example, here above 300, despite no prior events, these patients have subclinical disease. They've never had chest pain or anything. They have risk of major cardiovascular events on par with those who have clinical ASCVD. So that level of risk warrants the same aggressive prevention strategy, LDL goes below 55. And for a deeper dive, I highly recommend Dr. Maron's presentation at the Right Care Initiative and this publication in JACC from 2024. So I just want to remind you very briefly with this slide that LDL is just part of a broader group of what we call atherogenic ApoB containing lipoproteins. So think of ApoB as standing for bad. These are the atherogenic plaque-forming particles. LDL makes about 90% of these, and that's why it's been our primary target. So this figure also highlights two other key players, lipoprotein A, that apart from the ApoB, has an ApoA moiety that is genetically determined and is in fact the most prevalent inherited dyslipidemia. It affects about 1 in 5 people, and it's the strongest genetic ASCVD risk factor. And we're so lucky today to have Dr. Knowles, who's going to give us an overview and explain more about this to us today. And the other lipoprotein, it's triglyceride rich, and like these include VLDL and IDL, and we can briefly calculate in our mind how much of these circulate around by dividing the triglycerides by 5. So we get an idea if these are remnants that are going around making our arteries even worse. So there's a key element also. Lowering LDL cholesterol or ApoB lipoproteins, it doesn't matter how we do it. We produce the same relative risk reduction. So that's why both the US and European guidelines now emphasize not just high-intensity statin therapy, but high-intensity lipid-lowering therapy, targeting ApoB particles, okay? So not just statins, whatever the patient can tolerate. And we have very good quality, high evidence guidelines. They're all comparable, Canada, the US, and Europe. And each of them reflect the most recent trial data, evolving approaches to high-risk lipid management. Just choose one. You're not going to go wrong. We do see, I want to bring out that there's a meaningful variation in the screening strategies. For some reason, the US were on charge here, and in contrast, the Europeans and Canadians that start a little bit later screen men over age 40, women over 40, 50, or postmenopausal. In the US, we're supposed to start adult screening at age 20. So reflecting a broader approach to earlier detection. So identify risk early, intervene effectively to prevent cardiovascular events. This slide is just something that I wanted to show briefly, how we can match treatment intensity to both risk and value. From an economic standpoint, combination lipid-lowering treatment makes a lot of sense and offers greater return in patients with high baseline risk and high LDL. So in this first graph here, adding ezetimibe to maximal statin therapy can induce a 20% LDL further reduction. And in the very high-risk patients, you see the number needed to treat here come dramatically down, right? If you, in these very high-risk patients, the number needed to treat is even lower as your LDL cholesterol at baseline goes up. So these very high-risk patients get a lot of bang for their buck. And also, if you lower it even more, adding to maximal statin therapy a PCSK9 inhibitor, and you achieve this 50% LDL reduction. Look at this, the number needed to treat goes significantly down. And this makes a lot of economic sense.
Summary: team-based cholesterol management, key takeaways. LDL-C is a causal and modifiable risk factor. Lowering LDL-C reduces ASCVD events in a linear, proportional, and duration-dependent manner. Earlier and more sustained LDL lowering leads to greater long-term benefit. Cumulative LDL exposure, or cholesterol years, drives atherosclerosis. Combination therapy improves outcomes. Ezetimibe and PCSK9 inhibitors offer additive benefit beyond statins alone. Therapy should target all ApoB-containing lipoproteins. Risk-based treatment strategies are essential. Tailor LDL-C goals and therapy intensity to individual ASCVD risk level and coronary artery calcium burden. Cost-effectiveness supports stepped intensification. Prioritize high-cost therapies, for example, PCSK9 inhibitors for those with highest absolute risk. Implementation requires system-level solutions. Team-based care improves access, adherence, lifestyle modification, and therapeutic intensification.